scenario. And we've gone through this before, but we have a lot of new staff. So that's one of the reasons I had mentioned like a few months ago to have maybe the new nurses just spend half a day or even a couple cases with me so I can just kind of talk about the things that we would ask for. But it really wouldn't be a bad idea even for the nurses who have been here for a while to do that. So MA, nurse, I literally don't care if you work in this unit. I want you to know these things because you might be the one that we ask to do to help us. And it could, seriously guys, save somebody's life. Like it really could. You do all this training for ACLS, the likelihood, knock on all the wood, of you actually having to use that compared to you actually having to assist us with an airway emergency or laryngospasm, like this is something you will have to help us do, without a doubt, if you work here long enough. So it's very important that you guys are familiar with these emergency airway equipment things. And then yesterday, Julie asked for Rocuronium. Who can tell me what that is, where it's located? It's in the fridge on the clinic side. What do we ask? What is it? What does it do? Yes. So Rocuronium, also called rock. You might hear us say rock, Rocuronium, Zemuron's the other name for it. 3 names. I want you to drill them into your head. Rock, Rocuronium, Zemuron. All are the same thing. Okay. Located in the refrigerator on the clinic side. Who knows the codes just like that to get in there? And then if you don't want to run all the way around, the code to get through that door and then into the med room. But does everybody know that?
Should.
But it's not one you use all the time. So I don't blame you if you don't. I pull out my phone. It's not like a trick question. I don't use those codes all the time. So when I go in there, I have to pull out my little thing on my phone. And in an emergency, who wants to be doing that? So I really think that the best thing we can do is if everybody has some kind of label or sticker on their badge, something they wear every single day, that will have the codes so that when adrenaline's pumping and you have to run over to get it, you can go like this and you have the door codes. I would think that that's what I would want. If that sounds like a good idea to everybody, I think we should fund it.
I gave everyone a cheat sheet.
Well,
if you
then,
don't
like,
have one, let
highlight
me know.
Red it, bold it, I don't care what you have to do, but like in an emergency, you think it's somewhere accessible, but your brain's doing all kinds of other stuff, and like it's gonna take you a while. Where is it? Where is it? Do whatever you need to do to have those codes on you so you know them, okay? This is what it looks like. It comes in this box, Rocuronium. I have started with all of our new nursing staff just pulling one at the beginning of the day, and I'm keeping it on the top of my cart, taped to the top of my cart with a 5cc syringe right there. Technically, it has to be refrigerated if you're not going to use it within like a certain time period. In the ORs, in the hospitals, we have it stocked unrefrigerated in our Pyxis in our cart, but we go through it like 1 per surgery, so it's okay. But when seconds matter, like I want it on my cart, and I'm really happy I had it on my cart yesterday because then Julie was asking for it in the other room, and instead of people having to run, which was pretty chaotic, people didn't know what we were asking for, didn't know where to find it. It was right in my room on my cart. So I'm just gonna start doing that. It's not going to go bad. I know it's like the recommendation for it to stay in the fridge. But if it was me having an airway emergency, like I would hope that the CRNA just had it right there. So I'm gonna start keeping it on my cart, which when you guys work with me, I'll kind of show you where I've been having it, but not every CRNA is gonna do that. That's why it's very important you guys know where it's at. We can pass this around. You guys can look at the box, get familiar with it. Door codes, I don't know if we should like put this somewhere, like there, the names, the door codes. I want everybody to know what they are. As far as this, I thought was very well known. If we ask for a bag, you grab this, right? Does everybody know that, right? I feel like I tell everybody who comes in the room, if we ask for a bag, we want this. Also called what? Jackson Rees, right. So it's our responsibility if we ever use one of these to get another one to replace it with, so it's always in the bottom of the cart. Put together, assembled, the mask should be there. There's been times, now I'm pretty good about telling all the CRNAs that this connector, it comes with a big bulky thing that doesn't actually attach to the tree. So I know in the past I've had times when Lindsay's like, oh God, it's not attaching, and like holding it on there. So now I just cut it off. Okay, so it should easily attach. This is the valve to give positive pressure. You can open or close it. That's how much pressure and force is going to be in this bag, putting pressure, positive pressure on those vocal cords to pop them open so that they break that spasm. We should always have it turned to off so that the second we put it on the patient in an emergency, it's already giving the full amount of positive pressure. And again, that's us, CRNAs. It's our responsibility to have, we check this every day. It's in our bottom drawer. But you guys need to know what this is if we ask for it. You've seen some of us, we have a patient that we like, oh, they might give us trouble. We'll just put it out on the counter before an upper, just so you don't even have to go to the bottom drawer to find it.
Crank the O2 up to 10 when that
Yeah,
happens?
just crank it up. Yep. And then we will probably need both of our hands to hold the mask, a good mask seal to fully give that pressure. So then we may direct you to help us squeeze the bag. So just be ready and listening for us to give you directions, just like in a code, right? You're just waiting for somebody to tell you what your role should be. Now, if for some reason this was not in the bottom drawer, or we're like, there's a weird hole in the bag, it's not working, what else do we have in the room that you could use instead? Bamboo bag, right? There's at least one in every room. Sometimes there's two. There's one like on your guys' little clear airway box on the wall or the counter, and then there should also be another one in our bottom drawer of the cart. Now, who thinks that they could just easily assemble this when they're nervous and the patient stats are 60 and the CRNA's yelling at you? Like, it's kind of tricky, right? Like, so we don't always have this all the way assembled. Most of us prefer this. I've told you guys before. The bag on an ambu is just stiff. This, it's like the patient's lung. It's almost like a lung outside of their body, so that it's flexible, so that if they're trying to breathe on their own, you can actually, I've showed you guys before, we're running low on them, so I don't want to waste one right now. Otherwise, I'd put it to my mouth and show you guys how it moves with a breath. But we can actually feel the patient's effort that they're putting into it when we touch this bag, and you can see it. Whereas with an ambu, you can't. So I think ambus are really just best for like code situations where they're not trying to do anything. You're just helping give breaths. But this is by far what we'll ask for the most. But we also have ambus. So I just want you guys to like play with them, pull them out, get familiar with them. One day during COVID, when it first started, we all came back, I pulled out all the ET tubes and laryngoscopes. I don't know if some of you were here and remember that, and you learned how to put those together and what we would ask for. We can always try to plan a date to do that again. Or if you guys are with me in the room, today, the nurses that'll be with me, I can kind of show you that. But it's very important. Like seriously, more than your ACLS, this will happen. You will be in this position where you have to help us with the laryngospasm, without a doubt. So, really important to know the airway equipment we'll ask for, know Rocuronium, where it's at, and those door codes.
Anything special, like if your hands are occupied, anything special about drawing it up? Do you want the whole thing?
It's just,
like,
it's a 5 cc syringe, and then we'll tell you how much we would want you to give, like as a nurse. Or honestly, if I had no other hands, I would ask like the GI doc or the MA to push and just under my direction in an emergency if I had to. So it's 5 cc's. For an intubating dose, you would give pretty much the whole thing. And then there's gonna be no effort. They're 100% paralyzed, their entire body. So you have to breathe for them now. What do we have? Does this just wear off on its own, or do we need a medicine to reverse it? Reversal, Sugamidex, which we have in our anesthesia tray. So that's another one that I'll kind of show you guys today to draw up. But you can break a laryngospasm with like a tiny bit of this, and it can be just enough to relax the vocal cords but not totally take away their respiratory effort. It sounds like that is what Julie had planned on doing if she were to give it, but we were able to break it. Like 99% of laryngospasms you can break with positive pressure. With that Larson maneuver you'll see us do where we push back here and do a real solid jaw thrust, or with deepening the anesthetic, give them more, which seems weird, but you want to relax them more to break those cords open. So we did not give rock yesterday, but I did run and get mine and drew it up, but we broke it without it. And I get it, it's scary. It's a scary situation, your adrenaline's high, but that's why the more you do things, like muscle memory will take over, right? And so like practice with this stuff or ask us. I might just start, I think Sam was like, just start pimping them, like quiz them randomly, be like, where'd you go give me the rock? Where would you get it? You know, just so it's in your mind, so like be ready to do that if you ever had to.
Can you talk a little bit about what actually did happen to help break that?
Just an upper endoscopy. It was a Bravo, bigger girl in her late 20s. She didn't really have any reactive airway disease, but you never know. And she just, all it takes for a laryngospasm, what that is you have your vocal cords, right? They're usually open. If something gets on them or if they're irritated, that can be too much lube on the scope when they put it in. That's why I hate all that big glob of lube that some of the docs will put on, because I'm just like, that's just headed for the cords. Or saliva. They think she was a Bravo, right? So she's always having reflux, probably. So sometimes we give them that first propofol, and then they can just have like a passive reflux, and that could have gotten on her cords and irritated them. Who knows? Could be any of those things. That makes the cords slam shut. They're mad. They're like, something's on me that shouldn't be on me. And so when those shut, you can't move air. You can't get air through them because it's closed. So you hear that squeaky sound a lot, or you'll just see like that paradoxical movement where they're trying to take a breath, but there's not actually chest rise. All those things that we're looking for. So she noticed that. I mean, obviously I wasn't in there the whole time, I came in later, but patient starts desatting. Most of you have seen this happen, and we correct it, right? And so then her and Dr. Zia were probably like, okay, pull the scope out. I need to bag her up, get her sats up. You guys have seen this, most of you. And that doesn't always mean we're not gonna do the case. Sometimes we're able to just like give some positive pressure, break it, get their oxygen sats back up, and then try again. And in this case, this patient was just not, she was very irritated. Her sats stayed 70s, maybe high 60s. Again, when I walked in there, I think it was like low 70s. Lips are blue, like she's not moving air. She still had the bite block in at that point. So then Julie was just thinking 3 steps ahead, which is what we should do, like get the rock in case I need it. With me in there, we were able to like move her on her back. She got better positioning, better like mask seal, and we broke it just with positive pressure. But it took a good like 5 minutes of assisting this patient with positive pressure to get her sats fully up, where she'd stopped squeaking and was actually moving air decently. So again, these aren't, in an OR setting, these are things that we deal with regularly, and it's not that big of a deal because we have an anesthesia machine behind us. We could just be like, oh, okay, this plan isn't going well. Give me 5 minutes, I'm just gonna intubate them. We don't have that luxury here. Like, we don't have all that here. We can't just decide to switch to a general where we tube them. Like, we don't do that. So we're trying to do everything to avoid that situation. So I know it's like, it is a scary situation, but it isn't uncommon, and we can fix it without intubating like 99% of the time. But to do that, we need your guys' help a lot. We just need more hands. So the patient did fine. They did not do the Brava though. She was irritated enough, and it took her long enough to really recover that they felt like they shouldn't try again, which I think was the right choice. So,
Did you put an airway in?
I put an oral airway in. I took the bite block out and then put an oral airway in. which again is something that the CRNA would direct you to grab or help with if they wanted to do that. Yeah.
Can you revisit the valve thing on the Jackson Rees?
You're with me this morning, right?
Oh, maybe room one.
Yeah.
Okay.
Yeah. I'll kind of show you guys.
Cool.
Yeah, I'm sorry. It's just, you know, we have gone over all of this as a group, but we have a lot of new staff, and I don't know if maybe we should just make it part of orientation, like from here on out, so that there's nobody that hasn't been shown this stuff, you know.
I have a question.
Yeah.
How long that rock can be out of the fridge?
Forever and ever.
Technically,
However long Casey wants.
technically, I should not have it out of the fridge just for a day and then put it back. It's still going to work. It's still going to work in an emergency. I would rather have it by me, so.
I was thinking
I'm gonna do.
will be, if they're okay to put one in in the morning and then we make a note, put it back in the fridge in the end of the
I mean, we
day.
could talk about that. I think I would probably say just leave it up to the CRNAs to decide if they want to pull it out and put it on their cart every day. That's what I would say, because it is a very dangerous medication.
I don't think we want that just sitting
No,
out.
I don't think that it should just be around for anybody to accidentally draw up or put somewhere else. I mean, what's that nurse in the news right now? She gave the like sister medication to this, Rocuronium, and killed that patient. She thought it was Versed. So it's a dangerous medication. I think it should be with us. Yeah.
Did you end up having to leave a sedated patient to assist?
No,
Okay.
luckily we were waiting to start.
Okay.
But that is, you know, I told Julie, that's just add it to the list of reasons. It's a good thing we have 3 rooms now. How many years where I was here by myself? A lot of days. Like, it's nice to just have more anesthesia people available to come help. Somebody else who speaks your language and like immediately knows what you need. And so that's good that most of the time now we should have we should have at least one other CRNA.
If you had someone sedated in the room, you
Which
could
I
not-
have had to do. Libby was in my room with me when we had Kim Terrell here, and we had an airway issue, and I was doing a colonoscopy and she was sedated. What I basically did was tell Broussard and Libby, I said, you know, propofol wears off quick. Now, if I were doing an upper, and that my patient was kind of like spasming, I would not be able to leave. But this colon, she was doing okay. I just told Libby, I unhooked my propofol, put it down. I said, just let her wake up, and then switch to conscious sedation. And they were like, okay. So, I mean, no, an anesthesia provider should never leave their patient. My responsibility is my patient that I consented, but in emergency situations, you just, in small units like this, you just do what you have to do, which I would do if there was an emergency or a code or something in recovery too. I would just gauge when I can safely leave my patient and help, so.
Is there a spot out here where that is kept? So say it happens in
An
recovery.
amber bag?
Well, just that whole giddy up.
Jackson Rees, no, and honestly, you guys probably would just be more comfortable throwing an on rebreather on or doing an ambu until we got out here. Because it takes some finesse and like practice to know how to adjust this valve, and I don't think we need to get into teaching you
So
guys
just
that.
whatever's in that. Yeah.
Yeah,
Cool.
just use your normal airway stuff, and then of course one of us will be trying to get out to help as soon as we can. Any questions? You guys feel good about maybe being with me for a case or something, and we can go over some of this? And I know it's going to be a review for a lot of you that have been in the room with me for years and have heard me like a broken record, but you know.
There's so much idle time in there. Why not be reviewing more
Yeah.
stuff?
So much idle time, especially